When I talk about localism here, that's a term used a lot in England, and it is devolution. So in the context I'm going to be talking about, localism is pushing things down from national government to local authority. Now this is going to be very much a personal overview of drug strategy and the provision of drug services over quite a period, but particularly focusing on the more recent times and the impact in London. And just as a bit of background, London has a population of just over 8 million, and we have 33 local authorities, 33 municipalities in that area. And as Paddy kindly pointed out, mine is, I suppose, the wealthiest, but it's all historic and we look after it very well. I'm going to outline how we moved from a very ad hoc system to a very centrally managed system, how that system evolved, and how we've moved to localism as a central government priority, but all that against a backdrop of reduced resources and also fundamental changes to how our health system is structured. And over that period, I've worked at both national, regional and local authority level. And it would be fair to say that my opinions and views have fluctuated over who knows best as I've moved around. Now, up to the 1980s, the UK had very few drug services. London had only a couple of clinics in the National Health Service. There were some doctors who were involved, and there were some charitable providers. We had hugely varying approaches. The evidence base was almost non-existent, and there was almost no central oversight at all. And then this happened, and the fears of the impact of AIDS suddenly got politicians very much more interested. And it wasn't just around HIV/AIDS, but we had growing use of heroin. There was growing numbers of people injecting, but overall drug use was also increasing quite rapidly. It was no longer a minor issue that only affected a very small number of people. And so there was a government response. So the government did actually start, the 1995 government did produce a drug strategy that set a lot of responsibility on local authority areas of bringing together partners to work together. Very little money, but there was a recognition that local areas could bring together local police, local social services, local health providers, housing, and that they were well placed to do stuff. But there wasn't any money until we get to 1997. We've got a new government. One of their priorities is going to be tackling drugs. They bring out their own new drug strategy. It's going to reduce the harm that drugs cause to society, including communities, individuals and their families. That's quite an ambitious target, but it is to be fair, it was going to be matched with resources. There was very little central infrastructure. It's in this period that I moved into the drugs field and moved into the Cabinet Office, where there was the United Kingdom Anti-Drug Coordination Unit, which had quite a grand title, but at the time I worked there had all of 7 staff. So not exactly an enormous bureaucracy. And the idea really was that we would try to do some central direction and local authorities would somehow cobble it all together and make it work against the national targets. What we did have was one of these. Every home should have one. A cash tap is a tremendously useful resource. I like telling this to my colleagues who are perhaps a little younger than me now, but there was a time when the biggest problem civil servants had was spending money. We had an additional £200 million just given to us and told to spend it quickly, and there was more that followed that, and it was actually quite demanding because we were starting from a very low base with very few services, but it would definitely come under the heading of good problems to have. But it did cause problems, but at that time drugs also had a very important resource. It had political capital. Drugs were important. The Prime Minister spoke about it, ministers spoke about it, and at the local authority level, chief executives of a lot of councils, or someone of that level, would chair the local drug action team. It was one of the key local structures. There is one thing though, if you're handing out lots of this, ministers and central government gets very, very sensitive about how it's being spent. If you're putting millions and millions of pounds out of the door and giving it to local authorities, you want to be very clear on what your money's buying. And we started to build a bigger and bigger architecture of central management, expecting people to reach specific targets. And one of the good things though is that we could expect a minimum level of service at a local level. And one of the big targets that we had was around doubling the number of people in treatment and improving access. And that was done. This slide here shows very clearly just how much waiting times dropped for people seeking drug treatment. And actually in a London context, this hides the fact that for many people, once they had contact with a drug service, you could actually access services in days, which was a huge change from 98, 99, when it wasn't at all unusual for people to have 6-month waits in some parts of the country. So you could see some of what the money was buying, but we did get increasingly demanding at the centre of what we wanted. And it was very focused. It was very difficult for areas to break away and do their own thing. So in some areas, they might have specific drug problems or issues perhaps, say, with alcohol that did deserve a response, but you could only spend the money that was coming from the centre on what the centre said you could spend it on. And we built quite an architecture around that. We established a national treatment agency, which had a lot of strengths, but it did limit what local authorities could do. At the same time as we were getting increasingly centrist, our politicians were talking more and more about localism and the desire to push things down to the local level, because as we've heard earlier from Ingrid, there is a lot of attraction and it's very democratic to let people locally decide. But it wasn't even just something that was happening in England. This is from the European Monitoring Centre on Drugs and Drug Dependency. It was an idea that was popular at the time, and it has got a lot of strengths. But at the same time that we were talking about this, we were micromanaging local authorities. And actually we had 198 indicators on which every local authority in the country was measured on by central government. We were actually spending an awful lot of resource on reporting back to central government what we were doing with the money they were giving us. It had become quite resource intensive. Now, obviously, celebrating is not quite the right word, but there's been a lot in the news today about the 10th anniversary of the big crash in 2008. The cash tap got turned off very quickly. 2010, we get a new government and we've got an official policy of austerity. The National Treatment Agency, who had been very, very important in monitoring and directing spend and local activity, were merged into the new Public Health England body, which had a very different role. At a local level, public health became a function, a responsibility of local authorities. But there was massive reductions in funding, and in many ways these continue. We also had a tier of regional government office structure before 2010. That went. In London we still had the Greater London Authority, but didn't have a tremendously important role, to be honest, around health issues. So where are we now? I did speak to a number of my colleagues who are responsible for delivering drug services in their areas, and I think this pretty accurately reflects what a lot of them feel. There is a lot of confusion and uncertainty about quite where we're going. We've got an increasing variation in quality of service and access to service across London. We still have, 33 local authorities commissioning services. Some areas are still very interested and prioritise drugs. Other areas not so much. They really are doing the broad minimum. And in some ways it's understandable. If you're struggling to pay for services for your senior citizens, how easy is it to prioritise funding for drug users? If you think of the crude political maths, where do you get your votes from? We also nearly lost HIV prevention work in London because no one seemed to think it was their responsibility. But fortunately, that was such a big issue. That was kind of noticed and picked up late on. But it shows that when we broke up the system, gaps emerged. Now, I wouldn't blame it. We have a big increase in drug-related deaths. There's a poster outside which highlights that. I don't think we can blame that on localism at all. But it hasn't helped in some ways, because I'm sure if we still had central monitoring and sort of leadership around drugs, I think there would have been a stronger national response. And to be honest, I find it rather shocking that 2 years of very high increases, and we're only really now beginning to think, is there something more we could do about this? We've lost a lot of our service providers. We have far less charities providing services. We've lost a lot of the specialist services that were embedded within our national health system. And that's a real concern, because although consultant psychiatrists are very expensive resources, but they are very valuable when you need them. And I do wonder where we're going to find that specialism within our main health systems in 10 to 20 years, because they're just not winning services to provide. They're not winning contracts to provide services in London, because pretty much whoever can pitch the lowest for the service is going to win it. So there's a very local, how do I get through my next 3 years contract approach, rather than where are we going strategically. We're in a position, there's been a lot of work in London done around hepatitis C. We've got a number of organisations, including NHS England, that are signed up to eliminating Hep C by 2025, but I'm not entirely sure how we're going to achieve it, because the mechanisms don't seem to be in place to deliver that on the ground to me. I'm sure we will, but I think it's going to be done on the goodwill and enthusiasm of key individuals, not because there's a structure there to support it. So, what's my feelings around localism and indeed the central approach? I think they both have their risks. I think it's very clear that it's important that we do all we can to ensure that areas have appropriate and accessible services. And in many ways, local areas are best placed to work out what their local community needs, but sometimes perhaps they need some encouragement externally to ensure they do that. Individual local areas aren't going to keep producing, or aren't going to produce significant evidence base. That's a national function. That's something that needs to be coordinated and promoted and given credibility centrally. Money is very important, but I think that the biggest thing really is around political leadership. We've got, as I say, if you like, a patchwork quilt in London now. There are some areas where there is good political leadership. People are still very keen to do what they can. In other areas, the quilt is getting very threadbare, and it does feel a little bit like we're starting to slide back quite quickly. Things are undoubtedly better than they were in 1998, but in a lot of areas they're not as good as they were in 2010. I think we probably moved too quickly. I think transition can take time. I think in England there was almost a flight of responsibility by some of our central agencies and senior civil servants. We just sort of went, I know it's all down to you locally now. You've got the budget, we're off to do something more interesting. And I do worry about the Cinderella services. It's not just drugs, there's others. A lot of local authorities haven't really taken on board their leadership role, or haven't embraced the role they have around commissioning. So I think localism has an awful lot of advantages. Devolution does bring services and decision-making closer to the people, but it does require strategic leadership and it does require political leadership. And I think that's probably, in many ways, almost as an important resource as having your cash tap, as having money to spend on resources. You need leadership and you need support, and I don't think all of that can be done at a purely local level. Thank you.